Good morning to all. As Michael just said, actually we've got two Michaels here, Michael Small and Michael Plank. It's a bit strange. But anyway, I'm Yvonne Stokes from the University of Adelaide, and it's a real pleasure this morning to be introducing the plenary, which is from our 2021 EOTUC medalist, Professor Michael Plank from the University of Canterbury in New Zealand. Much could be said about Mike. He's had a stellar career, but I'll just say a few things. Mike is an expert in mathematical modelling of complex biological and social systems at multiple scales, from intracellular signalling and collective cell behaviour through to large ecosystem dynamics. His research is transdisciplinary and application driven. He has more than 100 papers or publications, which are a blend of novel methods and results in applied mathematics, as well as application-focused models that have impact in other disciplines and outside academia. So he's published in top-ranked journals, been an invited speaker at international and national conferences and workshops, and also won significant grant funds. But in addition, he's had tremendous impact, and I'll just give a few examples to illustrate this. He is a member of the New Zealand Prime Minister's Chief Science Advisor expert panel on New Zealand fisheries. In 2019, he presented at an international congress on the prevention of child abuse and neglect. And he has, I believe, for a number of years now, unfortunately, been co-led the team modelling COVID-19 in New Zealand and advising the government on its policy and operational response. Mike's career has also included considerable service to the ANZIAM community. So he's been a leading member of the New Zealand branch of ANZIAM, including as its chair or president. He's been on ANZIAM's executive committee, and he was also the co-convener of ANZIAM22, which was in Nelson. Probably many of us will remember that. So more could be said, but rather than eating too much into Mike's talk time, I'll now hand over to Mike to tell us about his work, which is on mathematical modelling of COVID-19 in New Zealand. So thank you, Mike.
Well, kia ora koutou. Thanks very much, Yvonne, for the introduction, and thanks to Michael and the invited speakers committee for the invitation to speak at ANZIAM. Before I start, I just thought I'd give a little bit of personal context to the work I'm going to be talking about today. I mean, some of you might have heard me talk at ANZIAM before about fish or about cells, and you might be wondering why I'm now talking about epidemiology. So before the pandemic, I'd done some work on epidemiological modelling, but it wasn't my main focus. So I must admit to feeling slightly trepidatious about giving an ANZIAM plenary talk on epidemiological modelling, partly because I sort of think probably everyone's sick of hearing about COVID and would rather hear about something else for a change. But really it's occupied my work life almost entirely for the last 2 years, so it really seemed like the natural thing to talk about. So, you know, how did this come to be? I think in February of 2020, I think perhaps naively, I sort of assumed that the New Zealand government would have a team of people ready to model COVID and to model a pandemic. But it became gradually clear that wasn't actually the case, and that there was actually a huge gap in this area. And at the time, I suspect, like many people, we were sort of following some of the mathematical modelling results that were coming out overseas, and we were playing around with some models of our own, and we sort of gradually started getting increasing requests for advice and increasingly asked to comment in the media. And it sort of really snowballed from there, and before long we'd found that we'd been seconded by the National Crisis Management Centre as it was then, and we've been closely involved really with the government response ever since. So it's certainly been a bit of a change in career direction for me over the last couple of years, but I was reminded recently by this quote, this nice quote by Anderson and May, in their famous textbook on infectious diseases. And I think this is one of the reasons why, as mathematicians, we actually have an incredibly useful skill set and a skill set that can be applied in lots of different areas. I mean, certainly to do that, there's a lot of work involved in getting to know that discipline and the subject-specific knowledge within that discipline. And often that's about building the right relationships and interdisciplinary collaborations. But I think, the understanding we have in this case of nonlinear dynamics, stochasticity, and using mathematical models to sort of rigorously interpret messy data can actually be incredibly useful in a variety of different situations. So as an outline of the talk, in two main parts. So in the first part, I'll talk about the model that we've used, the main model that we've used. We started using this model in March 2020, and we've refined it and added various bells and whistles since then. So I'll describe some of the features of that model, and then in the second part of the talk, I'll talk about some of the policy applications, roughly in sort of chronological order. So the model I'm going to talk mainly about today is an age-structured branching process model. So you will, I'm sure, be familiar with this sort of idea of a branching process to model an epidemic. In a classical branching process, there's no sort of accounting for the buildup of immunity or the depletion of susceptibles, but you can build that into this class of models relatively easily by just tracking the depletion in the size of the susceptible population. So whether there's some control measures or some level of immunity in the population will prevent some of these infection or transmission events from happening in the branching process. So the equation that we use to sort of define this process is an equation for the average number of people in age group J who are infected by an individual in age group K at a single point in time. So there's a lot of things going on in this equation, and then in the next few slides I'll break this down a little bit and focus on some of these terms and what they mean and how we define them. But broadly speaking, you can divide this process into three components. So there's transmissibility of the pathogen, and that includes transmissibility between age groups and over time. There's control measures that you use to try and reduce transmission, and there's the susceptibility of the population. So let's have a look at some of these sort of ingredients in this model. So one of the key ingredients of the age-structured model is what's called a next generation matrix. So this is really a matrix that is the average number of infections in age group J by an infected person in age group I, given a fully susceptible population. So there's some estimates for contact matrices that were published before the pandemic that are based on survey data. So surveys of people asking them about how many contacts they have in different situations like home, work, or school, and in different age groups. And this study combined that survey data with data on different countries' population demographics to estimate a sort of contact rate or a contact matrix, which is what you can see here. There's a couple of other things that affect this next generation matrix. Probably the most important is an age-dependent susceptibility term. So for COVID, this is the estimate that we use, that there's an increasing relationship between age and susceptibility. So that affects the rate of transmission between age groups in this model. The other ingredient in here is individual heterogeneity. So each infected individual essentially has their own sort of multiplier on the front of this equation that's drawn from a gamma distribution. And the variance of that gamma distribution corresponds to the the amount of heterogeneity between individuals in terms of how many people they infect. So that's characterized by this parameter K, which is sometimes called the dispersion parameter. So for SARS-CoV-2, empirical estimates of this parameter generally somewhere between 0.1 and 0.5, so somewhere around here on this curve. This is a really nice model by James Lloyd Smith et al. From 2005 about super spreading. So essentially, the more variance you have in this gamma distribution, the more super spready your pathogen is. So the more variation there is between individuals. One sort of possibly slightly counterintuitive thing about super spreading is the more dispersed your offspring distribution is, actually the higher the probability of elimination of a single seed introduction. Because you have some people who infect a lot of people, you also have some people who don't infect anyone, and so that heterogeneity means you have a higher probability of elimination. I think that's been one of the counterintuitive things that people in policy perhaps to wrap their heads around. I can't remember the number of phone calls I've had from journalists completely baffled as to why you could have a single case of this highly infectious new variant in a completely susceptible population, and yet it doesn't cause a large outbreak. And we've seen this effect happen in New Zealand and in Australia because we've had such low prevalence for long periods of time. One of the nice things about these sort of branching process type models is you're not tied to exponentially distributed waiting times between compartments. So you can have arbitrary probability distributions over time. And a couple of examples of that here. One is the generation time distribution. So you can specify that to be any probability distribution that you like. We use this Weibull distribution, sort of gamma-shaped distribution, essentially, which says, most of the transmission is occurring around day 4, day 5 after infection. But you've got this distribution that's spread out over sort of 10 to 12 days in total. The other thing is that this enables quite a sort of flexible model for case isolation and contact tracing, because you can model the time at which people get tested or at which they're contact traced and put into quarantine. So we can parameterize this contact tracing model with, the key parameters are the probability of getting tested after symptom onset, and the proportion of contacts of confirmed cases that are traced, and the times that those things happen. So the time from symptom onset to testing, and the time from the notification of an index case to the time at which that person's contacts are put into quarantine. So we calibrate this model with data from data on time of symptom onset and quarantine. Then the other side of this is the susceptibility, and a big part of that is vaccines, obviously. So the way we model this is what's called a leaky vaccine model. So essentially, you've got your susceptible population. Once you get vaccinated, you move into a 1-dose or a 2-dose compartment. Vaccines, as everyone knows, aren't perfect. So they don't completely prevent you from getting infected. So you are still susceptible, but it reduces the probability of infection by this vaccine effectiveness parameter in here. So there's still a force of infection on these vaccinated susceptible compartments, but it's reduced by the effect of the vaccine. Here are the vaccine effectiveness parameters that we use. So this is for the Pfizer vaccine, because that's almost exclusively what New Zealand has used in our vaccine rollout. 1-dose and 2-dose, you have different level of effectiveness. And then on the graphs on the right here, you can see this is basically data that is the proportion of each age group, 5-year age group, that is vaccinated with either 1-dose or 2-dose over time. So much like Australia, the bulk of our vaccine rollout was in the second half of last year. This third graph here shows the proportion at the population level. of 1 dose and 2 dose coverage. And then the final graph here, that shows the modeled effect on the reproduction number. So you can see throughout the second half of last year, a pretty steady decrease in the reproduction number as a consequence of vaccination. And then that's leveling out as we've sort of got through the bulk of the vaccine rollout and before we started with the booster program. We can model clinical outcomes, so hospitalization and death in this model as well. So obviously we've got a hospitalization rate that's an increasing function of age and a death rate that's an increasing function of age. And of course, the vaccine also reduces the risk of those things. So we've got vaccine effectiveness, depending on how many doses that infected individual has had, and the hospitalization risk or the death risk for that person's age group. So, relatively simple model. You can have much more complex model of clinical pathways that sort of model progression through different stages of severe disease, through ICU compartments and so on. We haven't really attempted to do that. We've sort of just used this relatively simple clinical outcomes model, but some of our results have been fed into other groups that are using that in a more detailed clinical model. So that's really a quick overview of the model. And so really, I probably want to spend more of the time just focusing on some of the ways that the model's been useful, I suppose, some of the policy applications that we've used over the last couple of years. One of the nice things about this branching process model is that it's not an explicitly individual-based model for everyone in the entire population. It only explicitly tracks individuals once they become infected. And so what that means is it is quite a versatile model, I think. It allows you to efficiently model small outbreaks because you're only having to track the number of people that are infected rather than the entire susceptible population at an individual level. But of course, it does allow you to model larger outbreaks as well, because it is modeling the depletion of the susceptible population as well. So, I mean, models like this, once you start to get large numbers of cases, they become essentially deterministic in the dynamics. But in New Zealand and in Australia as well, we've spent large parts of the pandemic thinking about risk assessments for small outbreaks. And so having a stochastic model has been important to doing that. So this slide really just shows a couple of examples of using the model in a stochastic sense and using the stochastic outputs. So the first one was that actually in the following the lockdown in April and May of 2020, we used the model to estimate the probability of elimination. And we were feeding into that the sort of, the daily case numbers and the number of, once we started to get a series of days with no reported cases, kind of feeding that into the model, using that to subset some of the stochastic realizations and estimate the probability of elimination in that way. So I think that was quite useful actually at the time for, sort of relaxing those restrictions, those heavy lockdowns that we had in place at the time, with a view to continued elimination of community transmission. The second one is that, once it became clear that we had eliminated the virus, we did obviously see border related cases and border reincursions from time to time. What often happened is you would detect a case and then you'd need to very quickly decide what to do about that. And so one of the things that helped inform that decision making was that we were able to use the model to estimate how many other infections were likely to be out there once you detect that first sort of tip of the iceberg. That's a function of the estimated reproduction number or the transmission potential, I suppose you could call it, in the absence of actual cases, but also crucially the testing rate. And we were able to sort of estimate what the probability of a symptomatic person getting tested was using flu tracking data. So it's a bit of a crude way of estimating, but it was the best thing we had. And I think it did help government officials get a bit of a handle on the fact that, okay, you've seen one case with one person has tested positive, but actually it's quite likely there could be 50 or 100 other cases hiding out there. A little bit further into the pandemic, we started modeling border controls. So this little flow chart here just sort of models a schematic model for different mitigations that you can put in place at the border. So things like pre-departure testing, symptom screening, self-isolation at home after arriving in the country, and different sort of testing schedules for arrivals. So what we did was to kind of couple this sort of border model with the branching process model for community outbreaks, and to estimate the effects of a particular set of border controls, border policy on the risk of a community outbreak that would necessitate some sort of control response. In other words, it didn't just sort of stochastically eliminate. So there's a whole bunch of numbers in this table for different sort of combinations of quarantine and self-isolation and testing requirements. I mean, roughly speaking, I think what this work showed was that with a kind of home isolation based policy, you can mitigate the risk from border cases. You could probably realistically hope for about an 80% reduction in the risk of a community outbreak. But it's not going to eliminate that risk altogether. And of course, the other thing that's really important to consider when you're thinking about border restrictions and sort of navigating a way through relaxing those border restrictions is the effect on travel volume. New Zealand, like lots of Australia for long periods of time, had a massive reduction in the number of international arrivals because of the limited capacity of MIQ. MIQ is managed isolation and quarantine, the hotel quarantine system that we operate at the border. So that bottleneck really reduced travel volumes. And of course, if you relax to a home isolation system, you potentially have a massive increase in the number of people arriving. And that's probably a more important effect than the reduction in risk that you get from some of these home isolation measures. A couple of other things that sort of came out of this piece of work is that regular use of rapid tests, so RATs as we call them now, we call them lateral flow tests in the paper at the time, but using RATs regularly, sort of on a daily basis, that can be as effective or possibly more effective than a less frequent PCR testing. So I think there's been quite a reluctance to use RATs in New Zealand. They were seen for a long time as less reliable, less accurate, and we've sort of tried to push back against that to an extent to say, well, yeah, but actually, if you're doing them every day, you can get a benefit from doing them regularly. There are trade-offs, but they have a place. Another thing that we've sort of been a common message, I think, that's come out of our modelling is that regular testing of border workers is crucial. This is probably something that's obvious and is generally accepted now, but early in the pandemic and early in the days of MIQ, we weren't really regularly testing those border workers, and I think we were conscious even at the time that was a key risk, that could be a potential risk for the virus leaking out of MIQ into the community. So we've done some modelling around testing frequency for border workers, and that has been taken up quite widely now. And particularly true after, as in Australia and New Zealand, we had our border workers for priority vaccination. Back in about February of last year, they were one of the first groups to get vaccinated. Still really important to test them after vaccination, because of course vaccination may not prevent those border workers from getting infected and transmitting into the community. It may be effective in suppressing symptoms, which actually might make them less likely to seek a test. So routine testing actually became more important. that stage. Modeling the vaccine rollout. So this was actually work we did this was probably mostly done in the first half of last year. And looking at the effect of a vaccine rollout over time on the reproduction number, and so the potential for the virus to spread in the population. I think when we started this piece of work, this was before the Delta variant came along, and we were all still quite optimistic that we'd be able to use vaccines to reach a herd immunity threshold and essentially see an end to the pandemic. Seems like a bit of a naive view now, but we were sort of a bit hopeful of that at the time. Once Delta came along, I think everyone realised that had suddenly become a lot more difficult because of the higher transmissibility of the Delta variant, and so I think this work sort of revealed that truth to government officials to some extent, and I guess highlighted the need that the vaccine, amazing as it was not going to be a silver bullet, and probably other public health measures were likely to be needed alongside the vaccine for some time to come. This slide here is a little bit of a digression. This is not really a modelling, or it's not something from the branching process model. This is really a statistical analysis and a collaboration with some public health and Māori health experts. But I put this here because I think this is actually one of the most important things we've done throughout the pandemic. So very early in the pandemic, in March and April 2020, I think there was a bit of an assumption that, or possibly a hope that Māori, who have a younger age structure than Pākehā, than New Zealand European ethnicity people, would be at lower risk because of the relationship between disease severity and age. So having a younger population would put Māori at less risk. But actually, our public health friends and our Māori colleagues were saying to us, well, yeah, but actually we know that that Māori historically in previous pandemics have suffered much higher rates of severe disease and death, and they tend to experience worse health outcomes across the board because there's a long history of a one-size-fits-all health system that doesn't serve Māori needs well at all. They also have higher rates of comorbidities in each age group as well. And so one of the things we did, this was in April 2020, was we used some data on some of those things, access to healthcare services and comorbidity rates in particular, to estimate potential differences by ethnicity in the infection fatality rate for COVID-19. And what that work, I mean, it was a little bit speculative at the time, but what it suggested was that Māori could actually be approximately double, after controlling for age, approximately double the infection fatality of New Zealand European ethnicity. So I think this really did sound the alarm bell that actually focusing on equity and prioritising Māori was going to be, hugely important to preventing a history from repeating itself, I suppose. Later in 2020, when we had an outbreak that produced significant numbers of hospitalizations, we did a comparison in the hospitalization rate, and really that bore out some of these predictions that we did see, a significantly increased risk for Māori and for Pacific people after controlling for age. We felt this was pretty strong evidence that a vaccine rollout should prioritise Māori, that Māori should be prioritised for vaccination. Unfortunately, the government didn't really follow that. And in fact, they've been widely criticised for that. And it was recently found by the Waitangi Tribunal that it was actually a breach of the Treaty of Waitangi. And one of the reasons being that they didn't really failed to prioritise Māori adequately in the vaccine rollout. So as I say, a bit of a distraction, but I think that was actually a hugely important piece of work. So back to a little bit of maths and back to the branching process model. So one thing I didn't mention, that you might have spotted in the equation earlier is that there's this function sitting in here, which we denote C of t, which we call this the control function. And that's it's a bit of a catch-all, I suppose, but it's a function that models the effect of different control measures over time. So early in the pandemic, with sort of strict lockdowns, we were just guesstimating numbers for this control function, really, that was the best we could do. Gradually we started to use data in a fairly crude way to estimate what reduction in transmission we were getting from our public health restrictions at the time. And so we, had some slightly more of a basis for this this control function, but it really was still a little bit of an educated guess. In the more recent Delta outbreak, which was from August of last year, we actually had sufficient data that we could do a slightly more rigorous fitting process on this. So we used a sort of a Bayesian fitting approach. So the idea is that you have some prior, sort of relatively non-informative prior for this function. We modeled this as a Gaussian random field, so it's correlated over time, but it can sort of jump around from week to week, and it can obviously take a range of different values. And so the idea is it's an approximate Bayesian computation type inference method where you basically do a gazillion stochastic runs of this model, and each of those produces a time series of daily cases, and you compare that with the data that we have on daily cases, and you compute some sort of error function, and you retain the sort of small fraction of those simulations that give you the best error function. And so by doing that, you take this uninformative prior and you end up with something that looks like this. So this is something that describes the best estimate that we have of this control function over time. So on this next slide, we're just going to dive into this control function and have a look at what this is telling us. So this was sort of from August through to Christmas of last year. So what we saw was first of all, a big decrease in that control function as we went into lockdown, and then exiting from lockdown, as expected, you see quite a significant increase in that control function as people come out from lockdown. So a big increase in the reproduction number, which is what you can see in this right-hand graph. And then in the next period, we're kind of gradually, incrementally relaxing restrictions, but relatively stable levels of mixing over that time. And so the dominant effect in the reproduction number was actually the rapid vaccine rollout that was in progress at the time. And so you see a decrease in the reproduction number, eventually bringing the reproduction number below 1, and then a relatively steady value for this control function after that. So, looks like no significant increase in mixing even after the controls were significantly relaxed and Auckland came out of its level 3 lockdown type restrictions. This way of doing it gives you a reasonable fit to the data. It doesn't quite get the age distribution right. We had a lot more cases in the under 20s than the model predicted, and possibly as a result of that, more cases in unvaccinated groups than the model predicted. But overall, doesn't do too bad a job at fitting the data. Of course, it's a different question as to whether it's predictive in advance, and that's moved around a little bit over time. In fact, the model did quite a good job of predicting this peak. We predicted that peak around about a month out, which we thought was pretty good going. But at other times, the predictions have diverged a bit from what happened. In particular, the cases dropped off after the peak a lot more rapidly than the model projections in advance. Last couple of things to cover from a modeling point of view. So more recently, we've built waning immunity into the model, and also with the arrival of the Omicron variant. So you can see here on the left some estimates of vaccine effectiveness over time, so decreasing with time since the second dose. After you've got your booster, please everyone go and get your booster. But after you get your booster, you get a big jump, but then a continued process of waning again following that third dose. So the way we model this, relatively simple way, is just a progression through susceptible compartments. So you initially start off with no doses, you have your first dose, you move into this first dose compartment, you move into the second dose compartment, and then after a certain amount of time in that second dose compartment, you move into the next one, which has a slightly lower vaccine effectiveness. So we use this model. So this is some scenarios for what Omicron could look like in New Zealand. We did this before the start of the current Omicron outbreak that we're in at the moment, because at that point we were holding Omicron at the border, but there was a sense that we weren't going to be able to do that forever. So we looked at scenarios around what could happen with different introduction dates. One thing that comes out of this is that actually, things get better to start with. So it's a bit tricky to see the colors here, but an outbreak starting in January results in quite a high peak. An outbreak starting in February is a much lower peak because we boosted a lot of people in that time. But then, going forward, because waning immunity starts to take over, these peaks actually start to get bigger again. A few sources of uncertainty to point out here. I mean, I think one of the biggest sources of uncertainty in these models is that we still don't really know what the intrinsic transmissibility and the generation times are for Omicron, and the model is quite sensitive to what you assume about those. So I won't go through all of those, but just in the last couple of slides, I just wanted to I guess reflect on some of the purposes and the contributions that modeling has made. I think probably any modeler who's been working closely on pandemic response over the last couple of years has at some point asked themselves what the point of it all is. And certainly when you're in the thick of it, it can be hard to lose track of that. I mean, at many stages, I've sort of found myself thinking, are we doing anything useful here? On the one hand, you're either saying something that's completely obvious, or you're saying something with such large uncertainty bounds that it seems completely useless, and often feels like there's not much in between. But I think when you step back and reflect, you realize actually that modeling has made quite a big contribution. I think modeling can be used in two quite distinct ways. One is the quantitative, the relatively short-term projections, and that's certainly been very useful in terms of situational awareness and getting a handle on where things are heading. But possibly the more important use is in a more qualitative sense, looking at more longer-term scenarios around strategic type questions or hypotheticals around different levels of vaccine coverage. And that kind of thing. So I think that's been quite helpful actually in guiding some of the policy decisions. And at a slightly broader level, I think mathematical modelers can play quite an important role in sort of challenging assumptions and revealing counterintuitive effects. I mean, we've met almost for 2 years now, really twice or 3 times a week with a group of officials from Department of Prime Minister and Cabinet, from Ministry of Health, and from Treasury. And I think that's a very two-way interaction, those two-way conversations between what we think is important from a modeling point of view, what our models are telling us, versus what's sort of coming down as the policy questions, and that generates a really useful conversation and some of the sort of counterintuitive effects that can come out of that. Exponential growth is an obvious one. It's something that's probably obvious to everyone in this audience, but is not always intuitive to everyone. What that can mean if you have a process that's doubling once a week or more than once a week, what that actually means. Some other examples here, one which I'll maybe just draw attention to, very obvious once you realize it, but wasn't obvious in advance at the time, was that when we were thinking about the Tasman travel bubble and the risk that that might bring, you know, that on the face of it, the risk of people coming from Australia at the time was extremely low. The prevalence in Australia was basically zero. And so there was really no risk, but the risk actually came from the fact that that MIQ capacity could potentially have been reallocated to people coming from high-risk countries. And that was where actually the bulk of the risk was coming from. And I don't think that was something that was necessarily obvious to policymakers at the time. So just I guess to reflect a little bit on future challenges. I mean, there are lots, but I suppose just to highlight a couple, one strategic and one from a research point of view. I think strategically here in New Zealand, I think we're still quite, you know, there's a lot of work to be done in terms of building capacity and systems and crucially relationships to provide, you know, real-time modelling advice when it's needed. There's this nice quote here from Chris Whitty he wrote this back in 2015 before the pandemic. And I think this is a really good quote, but it's also worth remembering that what you're able to do 80% right in a timely way really depends on the systems and the processes and the relationships that you've built before the crisis comes along. We've spent too much time feeling like we're trying to build an aeroplane at the same time as flying it, I think, and we need to put more work into preparing and to making sure those systems are ready to go. The other thing from a research point of view, I mean, the biggest thing that models have struggled with and continue to struggle with, I think, is modeling human behavior. This graph here is a graph of cases in the UK. I suspect if you'd shown this to an epi modeler before the pandemic, they probably wouldn't have believed this was a real case trajectory that you could see in a pandemic. And I think, you know, behavioural effects are playing a huge role here, as they have done throughout. So yeah, lots of work to be done here. I think, you know, there's scope for tapping into different data sources, more collaborations with social science, and really thinking about which policies are effective at achieving the desired behaviours. So this is really my last slide. So before I open up for questions, I've got a bit of an indulgence, which is a 1-minute video that I'm going to play that's nothing to do with modelling or mathematics, but it's an important video to me because I think it actually speaks a little bit to this point about what is an effective policy and what is an effective way of communicating that policy. I think science communication has been massive in the pandemic response. I think everyone from New Zealand will probably instantly recognise this video, but possibly people from elsewhere haven't seen it. For me, this is just a really effective piece of public health communication, and I think the style of it stands in contrast to some of the types of messaging that we've seen perhaps more in other countries. So I'll play the video. It's a 1-minute video, and then I'll open up for questions after the video. So hopefully I can get this to play.
Our rituals, our togetherness, our normality, our lives. This is not what we're giving up. This is what we are saving. So when you look around, don't see the emptiness. See the power of our unity. To lose could only take one of us. To win, it will take all of us. Be strong, Aotearoa. Kia kaha. Be resolute. Kia maia. The stronger we all are today, the sooner we will welcome tomorrow. Stay in it. Stay united. Kia manawa nui.
So thanks very much. Acknowledgements, many people contributed to this work, and probably only some of them are on this slide, but with that, I'm happy to open up for questions.
Thanks, Mike. So I think questions are coming via the Q&A, which I can read out. Would you like me to read them out? There's a couple there already. So the first one from Graham Hocking: is there a case to open up when the community is optimally protected in some sense, rather than waiting until everyone has been boosted, given the diminishing efficacy of the vaccine?
Yes, I sense there's a political aspect to this question. I mean, there's an element of truth to that, but of course, you know, if you can look at, for example, the results that we see in the models, which showed that sort of effect. So if you wait longer, immunity starts to wane. You've run out of people that to boost, and so waning immunity starts to dominate over increasing immunity from vaccination. So in that sense, yes. You do have to be really careful in interpreting these models in a quantitative way, particularly because, I mean, you might look at a model like that and go, oh, the peak gets bigger, or the total number of hospitalizations gets bigger if you wait beyond a certain amount of time. But you also need to think about who is bearing the brunt, who's bearing the health burden of that outbreak. You know, we have huge inequities in New Zealand anyway, in terms of that. And Māori and Pacifica bore a huge health burden in the Delta outbreak, partly because they were essentially put at the back of the queue for the vaccine rollout, and they're therefore at the back of the queue for boosters as well. And so the burden of who is getting infected is actually really, really important, as well as, you know, just looking at total numbers. So in a specifically narrow sense, yes, but there are lots of other broader things that I think have to be taken into consideration as well.
Yes, I don't know if you can see the chat, but you've got a whole batch of clapping your talk.
Oh yeah, I'm just opening the chat up now. Yeah, okay. Yeah, I can see lots of hands.
Yeah, a few more questions too. Eduardo Altman: how important is the choice of the type of epidemiological model? Can data be used also to compare different models? For instance, the branching model with other traditional epidemiological models?
I mean, I think what's most important is the parameter assumptions that go into any model. For things like transmissibility, disease severity, and vaccine effectiveness. In terms of the class of model, I mean, you could use an SIR type framework, either deterministic or stochastic, and you would get, you know, if you did the parameter calibration, you would get very similar results, I think. So the class of model, I think, is probably less important. Of course, different models allow you to include different levels of detail or different processes, and you know, that's important from a modeling point of view, and depends on the types of questions that you're interested in, or you know, what's important from a policy point of view. But yeah, the class of mathematical model, I think, is less important than some of those other things.
Have you seen sort of similar results from different models, or?
Yes, and in fact, when we modeled the vaccine rollout, we used the model that I described, the stochastic model, alongside a more traditional SIR type model, and we calibrated those and showed that yes, they produce very similar results.
Okay, next question from James McCaw. You commented on periods where uncertainty was large or overwhelming. How did you go about explaining what that meant and what could be taken from the models in such circumstances?
That's a good question. I think, I mean, I think we've probably got better at it over time, and better at communicating. You know, the model doesn't just produce you this answer, it produces you an uncertainty range. Often the uncertainty range that you get out of a model is you know, quantifying a specific contribution to uncertainty that's associated with the stochasticity of the model and whatever parameter uncertainty you've modeled, but it probably ignores other sources of uncertainty that either just aren't in the model or are to do with, you know, inaccurate parameter assumptions or something like that. I mean, I think what's been really crucial is that two-way dialogue between modelers and government officials, and that over time they've come to get a much better sense of the uncertainty and how to interpret model outputs, and what that means. So I think that's been one of the good things about this work and how it's panned out, is that we have been fortunate to work with a very quantitative and very you know, responsive group of people in government who are able to form a really effective bridge between academics and policymakers. You know, they understand the models. They're not modelers, they're not mathematicians, but they understand the models really very well, but they also understand the policy landscape. And so, yeah, that bridge has been really important.
Sure. Okay, the next question is from Scott McHugh. The ongoing and future research in this space seems overwhelming in terms of keeping up with new data and new government regulations and new variants. Is there a government-funded research body in New Zealand that will take on the bulk of this research? Perhaps the National Centre of Epidemiology and Population Health that Jeff Mercer used to work at?
Yes and no. There is a strategic science investment fund that is supposed to be starting mid this year. It remains to be seen exactly what that will look like, but it does have a significant amount of funding earmarked to it. And you know, I'm hopeful that building mathematical modelling capacity for infectious diseases will form part of that research platform. I mean, the way we've been funded has been really not that great, I have to say. You know, we've sort of been funded on a series of short-term contracts that yeah, anyway, I won't get into that, but yeah, I think hopefully things are moving in the right direction, but you know, I think establishing some sort of centre like that would be helpful.
Yeah, I know we've gone over time, but anyway, you're getting a rash of questions. This is a topic people can think of questions for you, I think. Do any of the models, this is David Warren, do any of the models you discussed here consider spatial heterogeneity? If yes, has this had a large effect on predictions?
So our model doesn't, and that's probably, you know, that's probably one of its biggest weaknesses, is that it's a non-spatial model, really. We've worked alongside and fairly closely with another team led by Dion O'Neill, who many people will know, Emily Harvey and Oliver McLaren. They've built a very detailed network model. It's basically a network model of New Zealand's population and the links between them and where they are, and you know, lots of demographic variables and lots of detail. So that is very much a spatially resolved model. And so those conversations between the modelers and the government steering group have involved both of those groups. And I think, you know, working alongside each other has been quite useful. There've been, you know, certain questions and certain sort of policy situations where that much more detailed network model has been more useful, and other situations where a sort of more coarse-grained model has been more useful. So it's definitely been valuable having both.
David Effery, I think. I don't know if I've got the pronunciation right. As part of communication, is there value in distributing or broadcasting the models to the public for them to play or interact with the parameters and to do their own modelling, e.g. having a website where you can run models interactively?
Yes, I think very much so. I mean, the public communication and public perception of modelling, that's a whole nother talk that I could give probably. And I mean, I think overall it's been positive. We've had quite a strong commitment to transparency and to publishing the reports behind the advice and the advice that we've given. And so that's meant we've put a lot of effort into public communication in the media, which has been hard work, very stressful at times, but I think it has been hugely important. We did at the start of the pandemic produce an app where people could play around with different assumptions and see what effect those have. We just haven't had the time and the resource to do that, throughout, with each sort of modelling update or each modelling scenario we've done, which is unfortunate, because I think that kind of thing is really helpful. But we have, for transparency's sake, published the reports, published the models, and put a lot of effort into public communication of that.
Zara Shariari, in the section on corona prevalence, you compared the time of outbreak and stabilisation with the rules of quarantine. Is it possible to estimate, given the different variants of the coronavirus, how the prevalence would have changed if there had been no quarantine rules and the government just focused on the vaccination? Is there any stabilisation period in this way?
Yes, we can. I mean, that's one of the big benefits of models, is that they're able to model counterfactual scenarios like this. And in fact, we did an analysis relatively early, which is published now, where we looked at what would have happened with different timings of interventions like border closures and lockdowns, back in the first wave in April 2020. So that's the sort of formal analysis that we've done. We did more recently also run, scenarios like what if we hadn't gone into lockdown with the Delta outbreak, if we had just sort of continued with relatively light public health measures, and with the vaccination coverage that we had at the time, which was around, 20 or 30% of the population. You can see that you have enormous numbers of cases, and you would be hitting overwhelmed healthcare systems within a matter of weeks at that stage. So the lockdown at that time really was necessary.
I've got a question that you might just chip in and ask is, have you looked at it at all at the time between immunisations? In particular, I mean, we have immunisations at 3 or 4 week spans between the 2 first doses, and then the period for the booster has been continuously ramped back. It seems almost political or economic, but I don't know if there's any data to support it. Do you have any?
I think it's been done from expediency as much as anything. I think, when boosters were initially sort of a thing, it was based on a longer gap, because there wasn't an urgent need to do it shorter. But the arrival of Omicron changed that, because it was clear that the booster, I mean, even before Omicron, this was true to a certain extent, but Omicron made it sharper, that you get a big increase in immunity after that booster dose. It's obviously reliant on the trial data as to what they've trialed and the safety data and so on. So it possibly takes some time, and that's not my area of expertise. It takes some time for that technical advice, I guess, to filter through that. Yes, a 3-month gap is still safe and effective. But once that advice was there, I mean, certainly in New Zealand, the government was pretty keen to shorten that gap, because the sooner you can get people boosted, the better protected you are against a coming Omicron wave.
And is there a too short a time where there's not worth doing it, do you think? Or
yeah, possibly. I don't actually know I don't have enough details to answer that question properly.
That's okay. Pratyush Kumar Kolapara, what were the parameters of the models estimated based on the initial outbreak, or were they updated as the epidemic progressed?
A bit of both, I think. I mean, we've kind of been in a state of constantly refining this model for a period of 2 years now. So at the start, a lot of the parameter estimates were basically guesses, or were sort of, or possibly taken from what modelling groups overseas were doing. With time, we've had data to inform different aspects of the model. So we've got some data relatively early that allowed us to estimate things to do with contact tracing and testing. It wasn't until the Delta outbreak that I talked about that sort of more rigorous method for estimating the control function through time. Obviously, estimates for vaccine effectiveness and things like that have been updated through time, and when new variants come along, you get a whole new set of disease severity estimates as well. So it's just a constant process, really, of refining those parameters.
Sure. Based
on international literature and local data.
Yeah. I know we're 10 minutes over. Michael's Small, is he? I don't know, he's there. Is it okay to ask the last question?
I think the last question is worth asking.
Yeah, sure. So again from Scott McHugh, Mike, following up on James McCaw's question, the well-known Canadian Jordan Peterson reckons if a model doesn't contain every single variable, then it can't be right. Do you meet that sort of ignorance?
It certainly exists. And some of the, I mean, you know, never read the comments, but if you ever read the comments on any sort of media article that's covering modelling, I'm sure you will encounter that view quite strongly. So it's certainly out there. I mean, one case in point was that there's often a bit of an information void here in New Zealand, just because there aren't that many people working in this sort of space. And so quite recently, some of the IHME, this is a Washington global model, some of their projections for New Zealand were picked up in the media without any sort of real context, and led to some quite unfortunate reporting, I think, about wildly high numbers of infections, and it was sort of grossly misinterpreted. And I think that is pretty frustrating, because that leads to a reaction that, oh, you know, these modelers just, they have no idea what they're talking about. It's all a load of rubbish. Can't believe any of it. I mean, I think that's one of the reasons we have put so much effort into communicating the modeling, what it is, what it isn't, what it can say, what it can't say, what are the limitations, what are the context. I mean, I'd like to think that has some cut through. It doesn't reach everyone, of course, and those views will still exist, but I think hopefully it does contribute to some level of understanding of what modelling is about.
I don't know, I have the feeling that public on the whole has become more favourable towards modelling. I hope so anyway.
Yeah, I hope so. I think so. I mean, I have a very skewed view of it, because I'm just, you know, the person trying to explain it the whole time. And so, yeah, you're probably better off asking other people how they think the perception is.
Yeah. Okay, well, thanks, Mike. That's brings the questions through the Q&A anyway to an end. And people can, of course, try and catch you around with their avatar, I guess. But anyway, thanks for a great talk on a very topical problem. So clap from me, and of course you've got all the claps in the chat.
Thanks very much.
Yeah.
Yeah. Thanks, Yvonne, and thanks everyone.
Thanks, Mike. Cheers.